in the area of transplantation. She's a Canada Research Chair here at the University of Alberta. She is the head of the pediatric, let me get it right, she's saying, she is. And as I said, really world-renowned. In addition to that, Lori is the director, the head of a brand new, relatively brand new, CIHR-funded research team. And I have a privilege to be part of that team, and so do our two speakers here. It's an interdisciplinary national team called the Canadian National Transplantation Research Program, and its home is right here at the University of Alberta. And Lori really was the person that made this happen, put it all together, and it's been a delight working with her to date, and it's been a delight working with my colleagues here. And with that, I'm going to turn it over to Lori to moderate what I know is going to be a controversial and fascinating discussion.
Thanks very much, Tim. It is a pleasure to be here over on the law side of things. As Tim has mentioned, the CNTRP is in fact newly launched in April of this year. It's a national coalition of more than 100 investigators looking at increasing donation, tissue and organ donation in Canada as well, and thus the accessibility of Canadians to the life-saving therapies of transplantation, as well as research directed at improving the long-term outcomes of transplantation, both organ and cellular transplants. So a key part of that is increasing organ donation, organ and tissue donation. There is no doubt that transplants save lives. That's been demonstrated time and time again. It is truly a miracle of modern medicine. But one of the key features that limits our availability to provide transplantation as a therapeutic option to the thousands of Canadians that need it is the severe limitation of donor organs that are available and donor tissues that can save lives. In the discussions about this internationally, there are many approaches that are being discussed broadly, and a variety of different approaches that are taken in all sorts of different countries around the world that are facing similar challenges. Clearly what we need in Canada is something that fits our legal system across the country, our demographics across the country, where we have this enormous geographic range and a relatively small population. So some of the issues are a little bit different than in the more populous countries of Europe or the United States. One of the issues that comes up then is how we encourage donation and how we think about it. What Tim hasn't told you is that he's the lead of our economics, ethics, legal, and social core of the CNTRP, and through his efforts and Robin's, we're trying to address this through initiatives such as you're going to hear about today. So our first speaker is John Gill. John is an associate professor of medicine in Vancouver at the University of British Columbia. He is also the current president of the society, the Canadian Society for Nephrology. John has a long, very dynamic history in transplantation medicine in Canada, particularly related to various aspects of organ donation. And he's going to talk to us first, and then we'll have our second speaker. John.
Thanks very much, Lori. Hi, everyone. I don't need this, I don't think, right? I can put this down. It's a pleasure to be here. I'm from Vancouver. It's a little colder here. Just to get a sense of who the audience is, I just ask a basic question. How many of you folks are registered organ donors? Just put your hands up. A little peer pressure, some people faking it. Okay. So here's my disclosures. The first thing is that I make my living doing kidney transplants, and that's, I think, an important aspect of this discussion. The second thing is I endorse the Declaration of Istanbul, and if you don't know what that is, you can Google it. It's basically a document that sort of helps the world tackle the issue of transplant tourism and organ trafficking. I think those things are important because, as my next slide shows you, this is a very polarizing issue. And so discussing the issue of financial incentives without getting entangled into a web of ethical, moral debate about transplant tourism and organ trafficking, which we all are against, is a difficult thing. And I think in Canada, we're uniquely poised to actually move the conversation forward, where really in the transplant community internationally, it really is at loggerheads. And there are divided camps and very heated, often very personal exchanges about this issue. So we hope in Canada here to take a fresh approach, and the key to that is respectful academic discourse, which, as I've alluded to, has already been a bit of a problem in the transplant community. And some of the things that I'm going to do, hopefully, in this talk are ask new questions, and really I'm going to sort of set the table in terms of practical considerations about the use of incentives in various forms in Canada, and that's really what I hope to accomplish in the next 20 minutes. My colleague Scott Klarenbach will, I think this will set the table for him to really go down to more detailed considerations. So here's the three questions that I want to sort of tackle. And the first is there a solid rationale for incentives in Canada? Because, paying donors for their organs is, got a visceral response for some people. And so before we go down this path, we have to say, are we on firm ground in making that judgment? And then I'm going to focus on practical considerations, and I'm going to walk you through some of the options which have been tried in other countries and that I know will be in the back of your minds about, well, what about these other things, and how do incentives stack up against that? So is there a solid rationale for incentives in Canada? This is another paper that I think is worth looking at, and this is recently published by my friend and colleague Arthur Matus, who's at the University of Minnesota. He's a Canadian from Winnipeg, and he really is the first and the leading person in the world talking about the use of financial incentives. And what he's proposed is a standard for a regulated system of organ sales, and you can see some of the key considerations that he says are fundamental to considering this. And so what this would mean is a country would really adopt a full-on system of regulated organ sales. So each country must have a legal regulatory framework with harsh penalties for wrongdoing. There would have to be transparency, subject to national and international oversight. The incentive would have to be provided directly by the state, i.e. there would be no payment between the recipient and the donor. Allocation would again be governed by strict laws with a single recognized system. And importantly, donations would be anonymous and non-directed. And that's really, from my perspective, in terms of thinking about this, is the major stumbling block in terms of considering this in Canada. Because the fact of the matter is our system right now, such as it is largely built on altruistic donors. And so this system, as envisioned by Arthur Matus and colleagues, really is for a country, in my view, that does not really have organ donation established in any way, shape, or form. And so that's why I've highlighted that. And so the key question from my perspective is can altruistic and paid donations coexist in the same system, which is what we would be thinking about if we were to move in this direction in Canada. So can these two things really exist in the same place? So with that sort of preamble, I think the key thing is for us to build a rationale for the use of incentives in Canada. And so in countries like ours, which have an established altruistic system of donation, financial system incentives might be justified if, and these are my opinions of if, altruistic donations have already been maximized. And so I'm going to show you some data about that specific point. And then the second point is altruistic donations are still inadequate to meet the need for transplantation. And so how does that stack up in Canada? And the important thing for us is we're heavily influenced by the United States. And I think we need to have our own data and information about this because we are very different. So this is something that probably you may peripherally know, and that is the number of deceased organ donors. So wipe the word cadaveric from your lexicon. It's not what we want to talk about. These are deceased organ donors and living donors in Canada. And you can see that basically over the last decade, things are pretty stable. They have not really exceeded. They're not really grown despite lots of efforts to grow these numbers. So basically stagnation. You can look at this another way in terms of donor rate per million population. You can see living and deceased donation in Canada really have not changed. How do we stack up internationally? This is data from the WHO. I could have given you a 2011 map. It would have looked the same. You can see Canada's in that sort of the color of my shirt, that blue. And so we're sort of mediocre, like as Canadians tend to be, with a range of about 10 to 15 per million donors, and you can see how we stack up against some other countries. When you put us, sort of rank us in order of deceased donor rates per million, you can see that we fall right in the middle of the pack, and I know you can't read all the countries there, but Spain is the super high ones, and then a lot of very developing countries with low GDPs are on the other end. When you look at living donation, you can see that Canada is definitely in the top echelon in terms of living donation, and we have a number of advantages for living donation, including advantages over the United States, including a universal health care system which allows lifelong health insurance for living kidney donors. So we have some significant advantages, but we stack up higher in living donation versus deceased donation. Now, having said that, do we have the potential to increase deceased donation in this country? And this was a study that we did, and we're working on publishing it. We've basically took all in-hospital deaths, and we've applied a bunch of criteria, and we said, of all people who die in Canadian hospitals, what proportion of them could be potential donors? And so just focus on Canada as a whole. During this time period of about 4 years and change, you can see there's about 335,000 deaths. Of those potential donors, by very strict and conservative criteria, were about 5,300. The actual number of donors during that time were 1,000, and what we call is a conversion rate of potential deceased donors, so people who die in hospital with diagnoses that are compatible with neurological brain death. Of those that actually went on to donate, you can see is only about 20% overall. Now, we've validated these numbers. These are done off discharge diagnoses from hospital separation, so administrative data, and we've recently validated this information against information from Manitoba. And basically our estimates overestimate by about twofold. So even if they overestimate by twofold, you can see there's still a sizable number of potential donors out there that aren't necessarily being identified and converted to actual donors within our existing system. When you look at why that might be the case, it's important to realize that there's really two different types, if you will, to simplify this, of potential organ donors. One is people who there usually are patients who have severe neurological brain injuries, and there's some that meet a criteria for neurological brain death, which requires 2 physicians and a number of neurological tests to establish that diagnosis. But there's a second form of donor, which is donation after circulatory death, which are individuals where there has been an independent decision. The patient doesn't meet criteria for neurological brain death, but even before there's any consideration of organ donation, the family and the care providers have decided that continuing care is futile and withdrawal of care is appropriate. After that decision is made, then and only in that circumstances can the issue of organ donation be breached in someone who still doesn't meet neurological criteria for brain death. And so you can see that DCDs, which make up about 30% of the donors in the United States and some other European countries, are really not being recognized in Canada at this point in time. And the real important thing is just to give you a sense of where we are. As a country, we're really not on the same page with regards to this. You can see in the very far column, the NDD are the neurologically brain dead donors, and the DCD are the donation after circulatory death donors. And you can see that places like Quebec and Ontario have much higher activity in donation after circulatory death donors, and the rest of us have not really caught up and embraced this form of donation. So there's this is just to suggest that there's lots of potential to increase deceased organ donation. Not to belabor the point, although we do well compared to other countries in terms of living donation, there are marked geographic differences in the use of living donation in this country. In British Columbia and Alberta, we're relatively high in terms of living donation, but other parts of the country, really a third of the activity that you see in some provinces. So clearly, there is differences and potential to increase this, as you can see there. So part one of the summary, is there a significant rationale to this? And I would say that there is significant potential to increase altruistic donations from deceased and living donors in Canada. So that first caveat that it was in that Arthur Maida slide that you had to have been maxed out is really not there. So I would reject a full-on regulated system of organ sales. But that doesn't mean that there might not be a role for financial incentives within an existing altruistic system. And you may say, well, that's an oxymoron. How can you have these two things together? And that's really where I think we're at on this subject. So what are some of the practical considerations and confines about trying to introduce incentives into a system that is primarily altruistically based? Now, we're in a law building. I'm not a lawyer, but you guys know this already, so we'll go very quickly. In each Canadian province, there's existing provincial legislation that effectively bans the sale of organs and tissues, And there's basically pretty broad sweeping language that prohibits any benefit from donation of tissues or organs. However, some practices, including reimbursement for donation-related expenses, are permitted, despite the fact that a secondary objective of these programs is clearly to increase organ donation. And so the question really is where is that line about what is permissible and what is not permissible? So there is some wiggle room, and I think I got that term from Tim, actually. So Canadian legislation is intended to prevent individuals from profiting, and any strategy that allowed donors to profit or indeed benefit would require changing of legislation. And I'm told that that is somewhere where you don't necessarily want to go. That would be a heroic undertaking to do that. So in my mind, where I'm looking to change the number of organ donors in Canada in the next decade, I think that that's a very, very tough road to go. In contrast, though, payments to living donors for costs related to donations are distinguished by the fact that these are reimbursements rather than benefits. So there are payments allowed for living donors, but this is really intended to, for them to recoup their out-of-pocket costs, which can be significant. There's only really partial reimbursement for lost wages. Some companies will, but that's the minority of companies. And in these programs that are set up, there's partial reimbursement, but you really have to be in the lower socioeconomic classes to really, so there's not full reimbursement of wages. So incentives that recognize the gift of donation in the case of deceased or living donation, or perhaps even for time, pain, and suffering related to the donor surgery might be permissible without changing legislation. But we don't know where that line is really, I think, one of the cruxes of the issues. So to summarize this section, changing the law is hard. There's limits on the value and nature of the incentives that would be allowed, and these limits are not clearly defined at this point in time. So what are the options? And I want to go quickly through this. I think I'm okay for time. Yeah, I'm doing good. So the first thing is presumed consent and opting out. This has recently been adopted by Wales, and you guys are probably aware that some high-performing countries like Spain have this system, and it's often thrown about, and in my opinion, ill-informed legislators get up on TV and say this is the way Canada should go all the time this comes up. And the problem is with opt-out strategies is that really they contravene the expectation of autonomy that's held by most individuals, donor families, health professionals, and in my opinion, this is unlikely to be supported in Canada. It's also evident from those in the transplant business that the Spanish experience, which is held up as sort of a shining light for the opt-out strategy, really their system did not take off until they made significant investments in their deceased donation infrastructure. So all the people that work in Spain will tell you that it was not the legislation that drove their improvements. Now, importantly, the data that we have in Canada suggests that it's not that families and patients are not willing to donate. What this is trying to show you, and I apologize, it's a small graph, is once a donor gets referred, so only about 35% of donors that are referred to organ procurement organizations, which are the ones that are responsible for going into hospitals and identifying donors, only about 35% of those are actually viable donors. But of those, once those people are identified, there's a very high conversion rate, upwards of 80 to 90%. And so it's not like if we don't ask the question appropriately and have professionals that do it in a way that is not threatening to families, that people will not consent to organ donation. Certainly, I still think there's room for improvement there, but I don't think it's the rate-limiting step. So that would suggest that presumed consent is not necessarily the best strategy for us. There's a couple of other issues with presumed consent. This shows you living donation in countries that have gone to presumed consent for deceased donation. And the bottom line is they don't go hand in hand. So if there is presumed consent on deceased donation, living donation suffers. And these things are interrelated, and we don't necessarily understand those relationships that well. So there could be a cost to doing this that's not well recognized. You probably have also heard of this very well-publicized Israeli model of deceased donation. And what they really did is they provided an incentive that was not monetary, but if you registered to be an organ donor, you got priority in the event that you needed an organ. So they prioritized you on the waiting list. And this has shown some preliminary promising results, and a lot of people are talking about it. It has some issues. From a medical perspective, prioritization for transplant based on non-medical considerations is potentially discriminatory and may not be accepted in Canada. What I would say to this is if we were talking about two different strategies to get people to register for deceased donation, on the one hand, if you didn't do it, you'd be excluded from getting an organ. And on the other hand, if you didn't do it, you wouldn't get an incentive. What would be the lesser harm? I mean, I think not getting an organ would be a much bigger problem. So I think that is something. And the other issue is obviously if a lot of people register as organ donors, who are you going to prioritize? So, you know, it has some inherent problems. Importantly, if you talk to Jacob Levy and other people who were involved in setting this system up, this was in parallel initiated with a massive public awareness campaign. There was buses everywhere. The sides of buses, billboards had stuff about organ donation on it. So the initial success may have been public awareness as opposed to the incentive itself, and it's very hard to tease out which of those two was the case. So if we turn back and say, why are potential donors not converted to actual donors in the hospital? If they exist, why are we not capturing them? One of the problems is our universal health care system is one where we don't like counting P's and Q's, and that's actually a problem. So we don't look at the costs related to deceased organ donation, and maybe we're uncomfortable to say, look, this is how much money it actually takes to secure a potential deceased organ donor in a Canadian hospital and reimburse that hospital, including the physicians and the departments involved, for the work that's required to do that. And we're not quite there. And that's an issue in our system, because what we're doing is we're piggybacking this on a system that is already strapped, right? So our ICUs don't have a lot of capacity, yet we're not funding this in a purposeful way. Just to give you a sense, you can spend a lot of money, between $0.3 and $1 million per deceased donor, and still have it make sense from a health economics perspective. Just to give you a sense, in the United States, for a kidney donor, the typical payment is between $30,000 and $40,000 for each kidney. Give you a sense of what happens in Canada. You can see in provinces that even have any form of reimbursement to the hospitals, it's very small. Okay. What I think we need to get our heads around is activity-based funding. Hospitals need to be reimbursed for all the costs so that we're not taking a bed away from another patient to secure deceased organ donors. Hospital payments need to be directed to the appropriate place where the activity is taking place, okay? The other thing that I think is really important is modest financial incentives within an altruistic system could be initiated. So if we gave people an incentive to register as an organ donor, and they only got the reward in the event of organ donation, from a health economics perspective, if you gave everybody the reward just for registering, and where very few people would ever donate the organs, that's probably not going to fly. However, if you restricted the award to if you actually were an organ donor, it might make economic sense. The secondary benefits for that are listed there, which I think are really important. It would get people talking about organ donation, okay? So there would need to be knowledge translation. You would have to set up mechanisms for people to register. And more importantly, if the hospital had a person who had been registered and was eligible for a reward, if you missed that person, that would be bad. So there would be a responsibility for the hospital system to capture all registered organ donors. So it might drive system improvement indirectly by having this small incentive part of the condition. What about living donation? And I'm going to end very quickly here now. So Canadian law will place limits on the value of any incentive that could be given, right? Now, could it be coached as a gift or a reward? It would have to be non-coercive, and perhaps payment for pain and suffering might be considered. We've been involved in initiating this kidney pair donation thing. This is the kidney swap thing, right? And basically it's people who have a medically suitable living donor, a kidney donor, but they can't donate to them because there's a blood group incompatibility or a tissue incompatibility. And so we've facilitated over 250 transplants now in this program by swapping these kidneys around. If you have more people involved in that system, it increases the efficiency and the likelihood that you could match people in that system. So the key issue here is could you get people who don't need to go in that system, i.e. they can directly donate, could you incentivize them to participate in the system? The attractive part of this is they've already made a decision to donate a kidney to somebody. What you're trying to do is to get them go in the system to multiply the impact of their gift. And so it's proposed as a non-coercive thing. And I'm just going to very briefly show you. These were previous living kidney donors and their recipients in our program, and a medical student of mine just did this. And what we did is we surveyed individuals to say, under what conditions would you consider having participated in this bigger program, given that you're already donating a kidney? And the important thing, as you can see, is donor travel expenses and full reimbursement for income seem to be important. But direct cash rewards, again, these are people who've already donated a kidney, didn't seem to be that big of a consideration. I'm going to end here right now. This is a list of strategies that I think might be acceptable within the current climate of Canada, and this is where the discussion, I think we can make some movement forward by having more discussion about these options. I'm going to stop there and give Scott the full 20 minutes. We can come back to this list at the end. Thanks.
Very much, John. That starts us off in a very provocative way, laying out the stage of where we fit in Canada compared to globally, and some of the basic issues that are needing to be discussed when we think about incentives for donation systematically. So Scott will take it from here. Scott Klarenbach is also a nephrologist, a transplanter here at the University of Alberta, and an associate professor of medicine. And he has a particular interest in economic issues involved in transplantation and donation, and he's going to hit on some of those just now, and then we'll have questions. Scott?
Thanks very much, Laurie. Thanks for your attention and the opportunity to speak. Tim, thanks for the invitation. So I'm going to take this from a health economics perspective. That's my interest. And I'm going to keep this focus relatively narrow. I'm going to talk about end-stage kidney disease, so people in kidney failure who are treated with dialysis. They were trying to get a kidney for transplantation. And I'm going to focus on living kidney donation. It's a practice that's been well established. People who are medically kidney to someone who has kidney failure to improve their health. So, and I'm going to talk a little bit about some of the economic side of things from the donor perspective, the healthcare system perspective, and then the particular interest in incentives. I like to keep things simple. For any strategy that we're looking at that we want to achieve, I kind of like to think of it this way. Does it work? Is it worth it? And is it acceptable? So these principles apply to the strategy of providing incentives, but also any other strategy that we might think about to achieve our objective, that is, increase the number of organs available for transplantation. So let's take a look at it from the healthcare system perspective. In kidney failure, transplantation is extremely straightforward. People do way better if they get a kidney than if they stay on dialysis on average. They live longer, their quality of life is better, and you save the healthcare system a huge amount of money. Most patients are in these first two slides here. I'm not sure if that shows up, but the HD ones, which costs close to $100,000 per year to keep them on dialysis. If you're able to transplant them, shown in transplant 1 year, the first year is quite expensive. They're in hospital. There's a lot of medications that are used. But then for every subsequent year thereafterwards, transplant 2 years, their costs are dramatically lower than those patients who remain on dialysis every year. So clear-cut healthcare savings. Some have estimated these healthcare savings to be around $100,000 per kidney that you obtain. And that's not even accounting the health gains that are achieved by this, between 2 and 3.5 years of perfect health for every kidney that's obtained. So clearly, this is something that we want. As John pointed out, we're limited by the availability of organs. And so we have to think about strategies that could potentially increase donation, keeping in mind, does it work? Is it worth it? Is it acceptable? Now, John mentioned the word altruism a lot. And just to correct Laurie, I'm not a transplanter, which is kind of odd why I'm looking at this field. I'm like, well, I'm a kidney doctor. I got roped into this from the health economic side of things. So when people talked about altruism, I want to know, well, what does that mean? People often use altruism as a way to dismiss a huge number of different strategies or thoughts. And altruism, if you look up the definition, is a selfless desire to improve the health of others or to help other people. But you know what? I didn't find that helpful. And in fact, it's always good to look at different disciplines. My horizons were broadened when I went from medicine and then learned economics. That might sound odd for those of you who suffered through your first year microeconomics courses. But it helped out from this and to look at utility theory or behavioral agency. And this is a framework of how people make decisions. So from an economic perspective, when we look at utility theory, people do things probably fairly selfishly. They do things to improve their health and to improve their wealth. I'm simplifying some of these issues, but we can subcategorize them by extrinsic, so they're external to you, so it might be material rewards or money. The intrinsic, so this would include a pleasure from a task, and I would argue this would include the concept of altruism, and then also signaling motivation, how you're perceived by others. So how do we put this together for the potential kidney donor? Well, clearly the intrinsic side of things, there's altruism. They want to help someone else. And the strength of that is likely modified by their relationship to the recipient. If it's your spouse, it's likely to be far greater benefit than if it's someone that you know from school or from work. There's also other intrinsic issues. For example, the impact of giving up your kidney on your health, both the surgical, short-term surgical implications of going through a fairly major surgery, as well as potential long-term medical consequences. And then there's the extrinsic side of things. So, and I would argue that there's both positive and negative economic consequences. If my spouse, for example, has kidney failure, they're on dialysis, they're not feeling well, they can't do stuff around the house, they can't really work. But if I give them my kidney, now they're able to engage in home productivity, workforce productivity, my whole economic status improves. However, there's the negative side that just by the fact of me donating, I might incur costs, I might lose my salary, there's cost for travel, etc. And signaling motivation, which we talked about as well. So how do we put that all together? You might have someone who is considering donating to their spouse. The benefit of altruism is huge. Their whole household and personal economic status improves. Signaling motivation, they're recognized by their family members. They're going to donate no matter how much cost they incurred. In fact, we've had people, the extreme scenarios where they want to donate their sole functioning kidney to their son. Now, obviously, we wouldn't let them do that, but I think it exemplifies how strong some of these things can be. And these are the people that financial incentives, they're unlikely to have any impact at all. And this might go to the point where John's talking about is saturation. Have we saturated altruistic donation? But you can imagine other scenarios where the distance of relationship might be a little bit distant. Perhaps it's a colleague or a friend or someone you know from work, and you want to help them, but man, 2 months off work, that's a lot of money, and then there's the pain, the inconvenience, and the surgery, that's not going to be very comfortable as well. Maybe I'm not going to donate. So the fundamental question is, would providing incentives change this green block, this green group of people who might consider donating but currently are not? So again, with the economic point of view, I'm going to look at the donor perspective and look at their negative economic consequences. And this is an example of how altruism, I think, in the past has led us astray. We wouldn't consider any issues around economics or paying people for their incurred expenses because of altruism. When we started looking at this a few years ago, we found out that the literature was very poor, but we suspected that a lot of donors were undergoing significant economic impact. We finally did a prospective study where we carefully measured what it costs for a donor to actually proceed with donation, and found that if you count up all the direct costs, the travel, the accommodation, the lost wages, that is around $3,000 per person. So we as a healthcare system were previously allowing these people to incur $3,000 worth of costs, which might be quite significant, especially if they have a loved one with a chronic medical disease. Over the last 5 or 6 years, this has been recognized, and several reimbursement programs have come up across Canada, including in Alberta over the last 4 years or so, but they still don't cover all the costs. Now, I guess the question would be, is there any empirical evidence that reimbursing these costs change donation? Well, we have very little direct evidence. The best study I could find was in the United States. They looked at several policies that were enacted from 1988 to 2006. And these were, they weren't far-reaching policies. They were primarily focused at state and federal employees and gave them sick leave or time off work to donate, or gave them a tax incentive or a tax benefit of $10,000. These are some of the examples. You don't need to look at the details there. What did they show? Well, they showed overall there was no difference in donation. But if you specifically looked at the living unrelated kidney donors, that is, they're not related to the recipient, they showed a small but significant increase in donation. So that fits in with the economic theory framework. If you have these people on the edge, they're considering donating, but maybe they're not, and you reimburse their costs so they're not losing their wages, perhaps some of them are changing their mind and they go ahead and donate. Now, does the same principle apply to a larger pool of donors? So instead of just reimbursing their expenses, if you provided a monetary incentive, could you increase donation rates? Well, this is controversial and polarizing, as John mentioned. There's all sorts of legal, ethical, and operational issues. I kind of got pulled into this because there hadn't been meaningful discourse, nor had there been really meaningful academic study from my perspective. It ended up being a polarizing debate. So I can't address the ethical and legal issues, but our group thought we could maybe potentially look at acceptability in Canada, its potential impact, that is, might it work, and is it cost effective? So is it worth it? We used the same context that John had lined out before in the previous paper by Matus. So it's a regulated market. Recipients don't pay anything. There's no direct discourse between the recipients and the donors regarding this payment. I'll skip through a few of these. You know the principle behind it. So we did a survey of Canadians. I guess this was published a little over a year now, where we wanted to determine the acceptability of expense reimbursement, that is, paying donors for their incurred expenses, the acceptability of financial incentives, and start to explore if incentives would change people's decision to donate. We did a questionnaire. We ran it through Ipsos to get the general population. We had 2,000 people that were polled. We also looked at people with kidney disease through the Kidney Foundation of Canada, through their Facebook page, and healthcare professionals, some of the major medical organizations in Canada involved with donation and transplantation. And what did we find? Well, for expense reimbursement, pretty straightforward. While we broke this down into several different categories, most people thought that reimbursing donors for incurred expenses, that should occur. The same thing for reimbursing their lost wages, although there were a little bit of split between if all their lost wages should be reimbursed versus some of them. But overall, pretty uniform agreement that this should occur. Where we start to see some separation is with financial incentives. So I'm going to break it down. Kind of the second one in talks about giving a government tax break to the person after the kidney is removed. And we had about 40% of all the different groups: healthcare professionals, people with kidney disease or their family members, and the general population. Where there was a little bit of difference is when you provide money directly to the donors. The general population thought that was okay. They said about 45% thought that was a reasonable strategy, but much lower for healthcare professionals and people with kidney disease. What's interesting is that these two are economically identical. They kind of mean the same thing at the end of the day, but one is perceived as being better than the other. And in fact, one might be less desirable because if you're not employed and you give up your kidney, you get no benefit from a tax break. But there was some acceptability for any or all the strategies. In the general population was much greater, about 60%, a little bit lower for healthcare professionals. What about those people who thought it was not acceptable? As you can guess, they kind of went to what we commonly say about organ donation. It's that it should be done from the goodness of your heart, and it should not involve any exchange of money whatsoever. Now, perhaps the most interesting is recognizing this is a survey. These aren't people who are actually making a decision. Who's looked at those people who initially said they would not donate or they wouldn't consider donating. And we said, well, what about if there was a payment for $10,000? So out of these 400 people who said they wouldn't donate to a relative, 54% said they would donate for $10,000. For a friend, similar numbers but a little bit lower, 24% said they would donate. Those who were previously unsure, the numbers are even greater. So out of the 750 people who said, I'm unsure about donating, now 78% or around 50 to 80% said, yeah, they'd consider donating to a friend or relative, and even around 20% to an acquaintance or someone they didn't know at all. We didn't see a lot of separation over the ranges of potential values. So going from $10,000 to $100,000, there's no real shift, which makes you wonder if some of this is simply a recognition. And actually we saw this in some of the work we do with reimbursement, that this cash might not be what makes the difference, but if it's money in form of a recognition of what they're doing to help someone else out, maybe that has an impact on the decision to donate. So I think there's consensus for reimbursement. There's some discrepancies about regulated financial incentives. It's a little bit of disparity. However, we did, at least from this survey, suggested that an economic incentive to potential donors might change their decision to donate. Is it cost effective? John laid out a framework where only anonymous donors would get paid. When we looked at the cost effectiveness, we thought about it in a different way. We thought that it'd be difficult to separate those things out. So we thought, and this is probably the most conservative approach, is that if you're going to provide a payment to donors, you'd have to give it to all donors, even those who were already coming forward altruistically. So we compared a strategy of paying all donors $10,000, and again, this third-party administered program. And we assumed that the number of donors would increase by 5%. So we thought that was fairly conservative given the numbers you saw in the survey. So for a program that has 100 kidney transplants per year, this would increase it by 5. We used a mathematical model that included all the outcomes and the probabilities and the quality of life and all the costs. And what did we find? Well, we found that if you paid $10,000 to every living kidney donor, that you would still end up saving the healthcare system money, and it would lead to net benefit in terms of health. Again, a dominant strategy, which means that, yeah, this makes sense. If it works, we should be doing this, at least from an economic perspective. Now, there's a lot of uncertainty here. What if we got a few numbers wrong? That's where you do sensitivity analysis, look at a number of different scenarios. The dotted red line shows $50,000 per quality, commonly used as a benchmark to suggest what is good value for money. The gray line at 0 represents where it's cost savings and leads to better health. And you can see there's a number of scenarios, percentages of increase in donation, as well as the amount of reward where providing an incentive would still be considered either cost saving or cost effective. So this is an exploratory analysis, a lot of assumptions, suggests that a plausible increase in donation might be cost savings or cost effective. Now I'm wading outside of my area of expertise. John's already talked about the Human Tissue Organ Donation Act, which I'm sure all of you are familiar with. No reward or benefit. I take issue with that. Altruism is a benefit to the person that's donating. I guess it depends how you frame these things. John had mentioned before that reward might instead be changed to compensation for pain and suffering and convenience. There's a precedence for this as well, at least in the United States, where if you're an egg donor, which is legal in the United States, it's an invasive procedure. 15% of those people come forward solely because of financial incentives.